Good afternoon. We are running so much delayed program today. Thank you very much for inviting me to deliver this lecture. I'll try to make it as much brief as possible. A slight modification of the topic I did, keeping in view of the clinical aspects. Ischemia-Reperfusion injury, what are the clinical manifestations and management? Ischemia contributes to pathophysiology of many conditions treated by us, including the MI, peripheral vascular disease, and stroke. Although all of us know restoration of blood flow to an ischemic organ is essential to prevent irreversible cell injury, but reperfusion per se may augment the tissue injury in excess of what produced by ischemia. So the damage caused by the reperfusion is more than what is caused by the ischemia. So the combination of ischemia reperfusion syndrome, the damage is more. So what is the definition of reperfusion injury? Cellular damage after reperfusion of previously viable ischemic tissues is defined as the ischemia-reperfusion injury. So coming to the cellular aspects of ischemia. So what happens during reperfusion and ischemia? You get an altered membrane potential, altered ion distribution, that is increased intracellular calcium and sodium, cellular swelling, cytoskeletal disorganization, increased hypoxanthine. These are all the things what can occur during ischemia and reperfusion. So what are the mechanisms of reperfusion? There is increased free radicals, increased calcium, and also neutrophil activation. I'll skip this. So the reperfusion produces a lot of oxygen-free radicals by various mechanisms. This is one mechanism by which the reactive oxygen species are produced. This is the mechanism 2 by which during ischemia, usually hypoxanthine is converted to uric acid. Instead of that, because of the oxygenation, the free radicals are released. The third mechanism is because of ischemia, the pro-inflammatory mediators are released, various mediators which can also damage. So these are all the free radical, oxygen-free radicals. So what is the definition of oxygen-free radical? Any atom or molecule possessing unpaired electrons. This is where the trouble comes. So nowadays a lot of research is going on in the oxygen-free radicals, and a lot of disease processes have been identified to be associated with the oxygen-free radicals and other react to oxygen species. That is why there is more research is going on, and lot of role of antioxidants have been are coming into the clinical practice usage of, and these are the biochemical effects of the reactive oxygen species. Various effects can come from cytotoxicity to DNA damage to additions of molecules, chemotactic and lipid peroxidation. All these can come because of the reactive oxygen species. Calcium overload is another mechanism by which there is cellular injury. So whenever there is ischemia, the membrane depolarization occurs because during reperfusion more calcium will enter and cause calcium load and damage to the other one is by whenever there is ischemia, excess of acid is there, which is exchanged with sodium, and calcium and sodium levels in the cell will go up, causing cell damage. Same way, leukocytes also release various complements and complement activation various. They all also lead to further cell injury, inflammatory mediators, oxygen-free radicals, and also injury of the microvessels, which lead to no reflow phenomena. All these also cause the excess of damage during the ischemia and reperfusion. So what are the clinical manifestations? What happens in various organs when the ischemia and reperfusion occur? clinical manifestations vary a lot. They're diverse. They range from transient arrhythmias in cardiac ischemia and reperfusion to development of MODs. And also they vary greatly among the individuals. The injury extent varies from organ to organ and also from individual to individual. Then what are the other things? What can happen is the myocardial stunning can happen. It is defined as myocardial dysfunction that persists after reperfusion despite absence of irreversible damage. This we see many a times when we vascularize the myocardium also, it doesn't pick up. Transiently there is a contractile dysfunction which is of course reversible. That is where it can be effective to use some inotropic agent or a mechanical support like IABP can help in recovering from the myocardial stunning. Other thing is the reperfusion arrhythmias. They are observed very commonly after thrombolytic therapy or cardiac surgery. They are result of a rapid and sudden alteration in the ionic concentrations within the ischemic region. So staged and gradual reflow can reduce the instance of this reperfusion arrhythmias. Same way cerebral ischemia and reperfusion is also a major thing after stroke, head injury, or after all these things it can occur. And it leads to disruption of the blood-brain barrier, which causes more damage to the brain cells which are otherwise salvageable. Same way, the ischemia-reperfusion of the GIT also is associated with many conditions, and it can lead to breakdown of the intestinal barrier, and also apart from that, it can increase the intestinal permeability and bacterial dislocation leading to MODs. So MODs is also ultimate manifestation of the ischemia-reperfusion syndrome. Many a times in our intensive cares, we resuscitate patients, but immediately they deteriorate in next few hours and they land up in multi-organ dysfunction. And from there, they undergo a downhill course. And when we look at this damage at the cellular level, it is mostly a result of ischemia and reperfusion syndrome. A patient who is in a hypovolemic or cardiogenic shock, you resuscitate him, you bring him out of that, but next 3-4 days when you see without any in spite of improvement in the primary condition, the patient goes into a MODs, which can be very clearly explained. The cellular death can be explained because of the ischemia-reperfusion syndrome. So, what are the main factors affecting? It is foremost is the duration of ischemia. The longer the ischemia, the more chance of getting into a reperfusion syndrome. Whereas, if there is a good collateral circulation, the patient won't get into a reperfusion injury. Because when you see reperfusion injury is more common when there is a sudden obstruction to the limb vessels rather than a gradual obstruction happening. Same way, it also depends on if the organ is very much dependent on oxygen supply, that is like brain and myocardial cells, they are more prone for ischemia rather than the tissues which can tolerate less oxygen supply. So oxygen intense organs like brain and heart, they suffer more because of the ischemia-reperfusion injury. And the condition of reperfusion, that is speed of reperfusion, is very, very important. The slower you do the reperfusion injury and the consequences are less. And composition of the reperfusion solution is also important. Other thing Dr. Mehta is very well discussed in the hypothermia. Hypothermia is single most protection against the not only ischemia but also of the reperfusion. So if the reperfusion condition is given in a hypothermic condition, the chance of this free radical formation, all these things are less. Then the extent of injury will be less if you give a reperfusion in a hypothermic condition. And this itself is another difficult and different topic, ischemic preconditioning. This is just nothing but a short period of ischemic stress given to the organ so that the organ can tolerate a longer period of ischemia. because the adaptive mechanisms will take place during these short periods of ischemia. And also a lot of inhalational anesthetic agents also have shown that they are beneficial in the ischemic precondition. Just one more minute. So what to do? Shorten the ischemic period if possible, which is not in our control, of course. That is where the door to needle time and all have come. As much as if you can reduce the ischemic period, the reperfusion injury extent will be less. Then reperfusion conditions, you give it a low pressure, low flow, and low temperature, lower pH, and lower concentration of calcium. I think that's one of the most important aspect. Lower temperature and the calcium are the two things which can limit the extent of reperfusion injury. How to prevent and treat? Scavenge the free radicals using enzymes and non-enzymes like allopurinol and all help in that. Relieve the calcium overload. Calcium antagonists have got some role to play here. Improve the metabolism, energy supplementation, and cellular protection. This is summary. Thank you very much.